Welcome back! Today we're tackling a fascinating little bug, a VRE that isn't really a VRE. We're talking about Enterococcus casseliflavus, an organism that can set off all the infection control alarms when, well, it really shouldn't. We're going to walk through, step by step, how to spot this imposter at the bench, and, just as importantly, how to communicate its true low-risk nature. Now, all the info for this explainer comes from a Gemini deep search. And as always, the full notebook with all the source material is linked for you down below.
So let's just jump right into the heart of the problem, shall we? A lab report comes across your desk. It flags a Vancomycin-Resistant Enterococcus. Immediately, for anyone in infection control, that is a huge red flag. It's an alarm bell ringing. But what if it's a false alarm? That is the exact dilemma that Enterococcus casseliflavus throws at us.
And this slide right here perfectly explains why. You see, on the one hand, you've got the really high-risk stuff, the transmissible resistance from vanA or vanB genes. These guys are usually on plasmids, ready to jump to other bacteria, and they absolutely demand a full-blown outbreak response. But then on the other hand, you've got intrinsic chromosomal resistance, like the vanC gene we're talking about today. It's built in, it's not going anywhere, and knowing this difference is everything when it comes to avoiding a massive clinical overreaction.
All right, to really get to the bottom of this, we're going to follow a classic bench-to-bedside workflow. We'll kick things off with the organism's basic profile, then we'll move to identifying it in the lab, understanding its genetic signature, then we'll look at the clinical syndromes it actually causes, talk treatment, and wrap it all up with the absolutely crucial steps for infection control and communication. Okay, Section 1. Let's start with the absolute basics. Who exactly is this organism we're dealing with?
So, Enterococcus casseliflavus is a gram-positive coccus. For most of us, it's a totally normal, harmless resident of our gut. It really only ever becomes a problem in vulnerable, usually hospitalized patients, making it a classic opportunist. But what's really key here is just how uncommon it is. We're talking just over 1% of all clinical enterococcal isolates. And its name, Casseliflavus, well, that's a direct clue from Latin, meaning yellow, which, as you're about to see, is a major hint at the bench.
Okay, so let's head into the lab. Picture this. You're at the bench, and an Enterococcus isolate lands in your workflow. What do you see?
At first, everything looks pretty standard, right? The gram stain shows your typical gram-positive cocci. On sheep blood agar, you've got smooth, non-hemolytic colonies. It grows just fine on McConkey as a lactose fermenter. And, yep, it's bile escalin positive, blackening the agar. It is screaming Enterococcus. But then you notice two key visual flags that should make you stop and think, wait a minute, this isn't my everyday Enterococcus faecalis or faecium.
And here they are. These are the two big giveaways. Unlike its more infamous cousins, Enterococcus casseliflavus is usually motile, and it produces that unmistakable bright yellow pigment. The second you see an Enterococcus that's moving and is yellow, your whole diagnostic thought process needs to shift gears immediately.
So those two flags raise your suspicion. Now, how do we confirm it? Let's look at how we can nail this down for sure using the biochemical tests and genetic fingerprints, often with molecular methods like PCR, that will definitively ID this organism.
This table just lays it all out so cleanly. You can see Enterococcus faecalis and faecium over on the left. They're negative for motility, pigment, and MGP. But then look to the right. Both Enterococcus gallinarum and Enterococcus casseliflavus are motile and MGP positive. So what's the final piece of the puzzle that separates them? That yellow pigment. It's unique to casseliflavus, and genetically it's carrying the vanC2/3 gene, not the vanA or vanB genes that cause all the headaches.
You know, I really want to hammer this point home. The MGP test is such an incredibly useful, simple, and cheap tool. If you've got an enterococcus showing any level of vancomycin resistance, running an MGP test can point you toward an intrinsic, non-transferable cause so fast, saving a ton of time, money, and worry downstream.
So here's the really cool part, the mechanism itself. The vancane gene doesn't actually destroy vancomycin. Instead, it cleverly changes the drug's target. It swaps out the normal D-ala building block in the cell wall for a D-ala-D-serin version. It's a subtle change, but it's enough to seriously weaken vancomycin's grip, making it pretty useless. And, most importantly, this whole genetic mechanism is hardwired into the chromosome. It is not on a mobile element. It cannot be shared with other bacteria. Period.
Okay, so let's switch gears. We've moved from the bench, now we're heading to the bedside.
We know how to identify it, but what kind of trouble does this bug actually cause in the real world? And who are the patients getting these infections?
Well, bacteremia is by far the most common thing we see, and there's a really strong link to problems with the liver and the biliary system. It can also cause a really nasty eye infection called endophthalmitis, which is often seen after some kind of trauma, especially farm-related injuries where soil gets involved. Less often, you'll see it pop up in infective endocarditis, peritonitis in patients with liver disease, and your standard healthcare-associated UTIs.
This right here is the absolute golden rule, the key clinical pearl of this whole section. If you see Enterococcus casseliflavus in a blood culture, your first thought, your immediate next step should be to investigate the biliary tree. It is a massive diagnostic clue that points you right to the likely source of infection, and that's critical for getting source control.
All right, on to the million-dollar question. How do we treat these infections? Let's take a look at the guiding principles for therapy. And what's nice is that these are pretty consistent across international guidelines, including those from places like the Netherlands.
Let's be 100% clear on this. The core principle is dead simple. Vancomycin does not work. I don't care what the MIC value says, it is clinically ineffective because of that intrinsic resistance we talked about. For any isolate that tests susceptible, ampicillin is your drug of choice. Full stop.
And this gives us a really practical look at treatment options. For a straightforward bacteremia, ampicillin all by itself, at a dose like 2 grams IV every 4 hours, is usually enough. But for something really serious like endocarditis, you need that bactericidal 1-2 punch. That's classically ampicillin plus gentamicin. And of course, if you run into an allergy or resistance, linezolid and daptomycin are going to be your main alternatives.
And here are the EUCAST breakpoints that actually guide our interpretation of those susceptibility tests. But look at that note for vancomycin. It's crucial. It should simply be reported as resistant. There's no maybe, no intermediate here, because we know the intrinsic mechanism means it's going to fail in the patient. We make our treatment decisions based on the ampicillin result, where an MIC of 4 or less tells us we're good to go.
Now, this is a really interesting and important point, a specific heads up for treating kids. While adding gentamicin is standard practice for adult endocarditis, the data suggests that for a simple bacteremia in children, it adds no real clinical benefit, but it nearly doubles the risk of acute kidney injury. That is a critical piece of information to help us avoid causing unnecessary harm.
All right, let's bring it all home. We've got the right ID, we've got the clinical context, so how do we make sure our response is proportionate? It all comes down to 2 things: smart infection control and crystal clear communication.
The response has to be measured. Standard precautions, that's a given, always. For the individual patient, yes, you implement contact precautions. A single room, gowns, gloves, that's just prudent to prevent spreading the organism itself. But the most important part of this slide is what not to do. Because the resistance is not transferable, there is no need for broad, expensive, resource-intensive outbreak measures like screening the entire ward. It's just not necessary.
And this right here might be the most practical takeaway of the whole explainer. How do we in the lab stop that initial panic? With this simple comment on the microbiology report, it is the single most effective tool we have. It instantly educates the clinician and the infection control team. It explains the why of the resistance, it clarifies the low risk, and it gives clear, actionable guidance for treatment. It turns a piece of data into real clinical intelligence.
And that really brings us to our final question for you. This organism is the perfect case study in just how important context is. So how can we, as a community of microbiologists, get better at communicating this kind of nuance to prevent these kinds of overreactions, both in treatment and in infection control? I'd love to hear what you all are doing at your own institutions, so please share your thoughts in the comments below. And hey, if you found this useful, don't forget to subscribe for more. Thanks for watching.